So I'm going to talk a bit about salvage options for PJI, and this is really when it gets to us. The ship is really sinking, and it's not a question of can we get it to float again, it's is there anything left that we can actually piece back together and make use of. I'm not going to go into any specifics. The nice thing about limb reconstruction is we have loads of fun ways we can try and put things back together. Half the time it feels like we're making it up on the spot, but if it works for the patient, that's great. But it's more about just the principles. Unfortunately, I'm going to upset Hemant. All the salvage options, as far as I'm concerned, are rubbish. So don't get to this situation is my first take home before I even get going. Because we talked about the treatment of PJI. And we've heard today about our various options for how we can treat it. All of them are published with success rates. The thing is, if your success rate is not 100%, by definition, you've got a failure rate. That's maths. So you will have patients where you've tried your best, you've done your revision, you've done your two-stage revision, it still isn't working. And the question at that point is, what is the next step? How can you make this leap from failure to success? Unfortunately, a significant amount of the time, you end up falling down that canyon. Because what do? So you can do another revision. You've done one, it didn't work. You could try and do a similar sort of thing again. You can up the ante and you can go from a dare to a revision, or if your one stage didn't work, maybe next time you'll do a two-stage. But I think in surgery in general, the more failures that you stack in an individual patient, the harder it gets. Life never gets easier in an individual patient. Because you end up, we've heard about this to an extent before already, so more and more problems with the soft tissues. You lose bone stock. You've had multiple courses of antibiotics, so you're more likely to develop bacterial resistance. So then you've got fewer and fewer bullets to shoot at them. And your patients just start to lose faith. Look, you've done this 3 times and it's not worked. Why is the 4th time gonna work? And psychologically, it's a big problem for patients, I think. So by the time you've had a few goes, your odds are going down and down. Everyone's seen this quote, and yet we all keep doing it, I think, and that's one of the weaknesses of surgeons. We do keep thinking the next time it's going to get better. But there comes a point where you have to accept, I'm not going to be able to deliver this patient an infection-free joint. So we then have to say, well, what are our options? Well, one which I'll mention briefly is live with your infection. So can you suppress it? Can you tolerate it? Because this is not a preferable approach. But if you've got patients who aren't fit for surgery, it's not a super aggressive infection, they're not systemically septic and unwell, they're able to manage their discharging sinus, it is possible to live with an infection for many, many years in some cases. I would always tell them at some point it's probably going to get worse, then it will force your hand to do something more. There is a debate about do you give long-term suppressive antibiotics or not. I'm not a huge fan. At some point, resistance is going to develop. At some point, it's going to break through, and then you'll be in a potentially even more difficult situation. But for a small group of patients where there's just nothing else, that is a potential. For the rest of them, we need to think about life without a joint, because we've heard about the biofilm on the implant. So to treat the infection, you're going to have to get rid of the prosthesis, and the biofilm will be everywhere, so all the metal is going to come out. But then we're worried about reimplanting metal because of this risk of recurrent infection. With the joint out, some of you who've been here previous years will have seen sort of similar slides to this. We revert to all the principles of bone infection anywhere else. So this is the same as for fracture-related infection or anything. We need to do all these things, deal with all these problems, and that gives us a slim chance of success. I think with PJI, these are particularly difficult because there's such a big lump of metal that you're taking out. You've got massive problems with dead space and bone loss and instability that you don't necessarily have to the same extent in fracture-related infection or chronic osteomyelitis. So I think this is, in many ways, the hardest kind of infections to get rid of. And we mentioned the soft tissues almost always become an issue at some point. So in terms of things we can do, does anyone recognize this gentleman? You must have seen this painting. I've walked past it every day at work for years. So for non-Oxford trainees, this is Gaethorn Robert Girdlestone. He was an orthopedic surgeon who was the first Nuffield Professor of Orthopedic Surgery in Oxford. This portrait is on the wall in the Nuffield Orthopedic Centre in Oxford. And you all know him, or his name at least, because of his publication of the resection arthroplasty, the Girdlestone procedure, which he did back in 1928. And this is his original scribblings on a patient's x-ray of how he was going to do the operation. It wasn't for PJI, which is one of the take-home points as well. So he described this for native hip septic arthritis, particularly TB hip, which was a significant issue at that sort of time between the wars. And his technique's very different. So he would do a transverse incision. He would excise a massive wedge of tissue, just everything goes. So muscle, tendon, trochanter, everything down to bone, take out the joint, pack the wound, and then put them in a spica cast. It wasn't a treatment for PJI because we hadn't invented the hip replacement by that point. But the name Girdlestone has become synonymous with excision arthroplasty, and so we use it slightly out of context today, but it's probably the most recognized named orthopedic operation around the world. When you're doing this, so you're taking out the implant, you're taking out all the prosthetic material, you're accepting there will be proximal migration because there's nothing to hold the leg out to length, and the remaining musculature will pull the femur proximally. So you will have a leg length discrepancy. You'll get some external rotation, and you're just hoping for a fibrous pseudoarthrosis in here so that everything gums together and has a little bit of mobility and hopefully has a degree of pain relief. In terms of how we do it, well, your approach is similar to your total hip replacement. My philosophy is I think you should always try and get all the metal and cement out in this circumstance, because you're doing this, you've tried treating infection potentially multiple times and it hasn't worked. I think you need to do everything you can to stack the decks in your favor. I know Tom mentioned in his talk, there is some series that suggests that maybe you can leave some cement in and it's all right. I think if you can at all get everything out, because you don't ever want to go back in there again after doing a Girdlestone, really. That's easy for me to say because I'm not necessarily doing it because I'm not a revision hip surgeon. I will accept that point. Having taken it all out, you've got this massive dead space and you have to control that, because if that just fills up with blood, that will then be culture medium, that will then have a high likelihood of getting reinfected. So as Hemant talked about, we do like using calcium sulfate beads as an antibiotic carrier. They produce a lot of antibiotics in this area, but they do dissolve, so you don't have to go back in and take them out, as opposed to the old PMMA beads, the bone cement beads that we used to use, which you're committing yourself to go to another operation to go and take them out. And if you've got this thing to heal, don't ever open it again, ideally. The trouble with putting that much Stimulan or your equivalent beads in is that as they dissolve, they produce an awful lot of fluid. And as was mentioned earlier, you do get very leaky wounds. And that can be a problem with wound healing. I know Jamie Ferguson's paper suggests that's not a problem. I tend to think it's a difference of scales, because that was more looking at their series of chronic osteomyelitis to an extent. When you've got this much, the volume of leakage can be quite a problem. There are potential ways around it. So much like Jay mentioned, filling a canal and then putting a joint replacement over the end of it, you can do a similar thing in a Girdlestones. If you fill the femoral canal with your beads, you can then put a plug of Cerament. Hopefully you've spoken to our sponsors at lunchtime. That sets hard, and it will actually hopefully contain most of that fluid in the canal. You can also line the acetabulum with equivalent Cerament. And it is possible, rather than putting more beads in there, you can do a muscle interposition, so you can put living tissue into that hole. The one we've tended to use for the hip is one of the quadriceps, either vastus lateralis or rectus femoris, which you can fill it out and fold back with your plastic surgeons. They do it. I don't need to do that bit. it's a right pain and it's a much bigger operation. So it's not, I'm going to do this for every girdle stone. But again, if you've tried and you're going back in and revising it and this is last ditch, it's at least something to think about. The muscle doesn't stop proximal migration, it's just a space filler. And does it work? Well, outcomes are varied. 80 to 100% infection-free. The 100% is a lie. There's no such thing. We know that there are certain groups where they have higher recurrence rate, including retained cement. There are publications that would suggest that it does increase your recurrence rate. But they generally do really badly. So in an elderly patient, less than a third of them will be able to mobilize independently around their house. 45% of them will not be able to mobilize at all. They'll essentially be bedbound after this. So you're committing them to quite a disability. And most of them have a fair degree of pain. So it's not a good solution. It may be the only solution, but I wouldn't sell it as something particularly great. Girdle stone is a name for hips, but what about excision in other joints? Technically, yes, you can do it in other joints. My feeling is it's only really acceptable in joints that are already intended for multiplanar motion, because your bone will go in whatever direction, it will flop in whatever direction it wants to when there's no joint there. So in a shoulder, you can do it. The soft tissues will just about tolerate it. Again, if you want to interpose some muscle, you can take some latissimus dorsi and fold that in to control some dead space. I think with more constrained weight-bearing joints in the lower limb, so the knee and the ankle, they can't tolerate that level of instability. It doesn't give you any level of function, so it's not really an option to my mind. So if we can't leave those joints floppy, the other option is to go the other way and actually fuse them. So stiffen the joint, take out the joint and just have a stiff leg. Here we're just aiming for a stable, stiff limb, hopefully that can weight bear, and hopefully if you've got a fused joint, it will control your pain. This, I think, is better tolerated distally. So ankle fusions, I think, work fine. Wrist fusions work fine. Knee fusions, okay. Hip fusions, again, technically possible, and shoulder fusions, technically possible, but not brilliant in terms of your function. And to go back to the problems, so because you've got so much bone loss, it's quite difficult to get nice bone surfaces that will unite together. And you will be generating a limb length discrepancy. So then you have to make a decision, do we just accept that and compensate with a big shoe? Or do we try and correct that by restoring length to the bone? You have a choice of how to stabilize, so you can fix it internally or externally. We're frame surgeons, so we're very biased towards external. But certainly in the fracture-related infection world, I think there's decent evidence that your recurrence rates are a lot lower if you're not putting more plates or nails back into an infected area. And as I mentioned, soft tissues definitely need, we would always involve our plastic surgeons at least in discussion for planning of these patients. So the bone loss, if you're taking out a big hinged knee like this, so there's 10 centimeters of metal and plastic before you even get to any bone, really. But then you've got to cut the bone so you've got a reasonable flat surface that will heal. You've got to get back to living bone that actually has the capacity to heal. You have to get rid of any infected bone. And it's preferable to have a size match between the two ends. It's just easier to get it to heal. So you don't end up with a gap of 98 millimeters. It's an extra centimeter or two on either side. So it becomes bigger as you do your surgery compared to what it looks like on your pre-op x-ray. There are different ways you can deal with that. So you could, in theory, try and acutely shorten the leg. So go from that to that. That would be great. It would eliminate your dead space beautifully. There'd be a bit of dead space in the middle of the canal you could fill with stimulant, but that's okay. Trouble with this is practically you can't really do it because you've got a longitudinal incision, and the more you shorten, even though you should have more soft tissue, it just bulges outwards and you can't get the soft tissues closed. It becomes harder and harder to close your wound the more you shorten, slightly paradoxically. And nerves and blood vessels just won't tolerate that amount of shortening. They're, 3, 4, maybe 5 centimeters at a push you can get away with. More than that, you're going to start having problems with the perfusion of your leg. Fortunately, with frames, we have the option of doing this a bit more gradually over a few weeks, and that is certainly something we will do to bring those bone ends together. The other advantage of a frame is it gives us the option of then lengthening the bone from somewhere else, so doing a corticotomy and using the frame to grow new bone with distraction osteogenesis. This is clearly me cutting and pasting. You would never actually be able to grow that much bone in a 75-year-old's frail elderly femur. They just wouldn't heal. So it's very difficult to actually do that to fully compensate. So yeah, these are the options really. So you can have patients in built-up shoes. When it's more than a few centimeters of thickening of the sole, it just gets ridiculous. You're trying to walk on a stilt as an 80-year-old with not great coordination, not great muscle power. They just can't really mobilize. So that's not a great option. Equally, trying to do a big limb lengthening on a 70, 80-year-old is also rather ambitious. And again, they will struggle to generate bone. So neither is a brilliant solution. The other option you can think about, which we do a lot less of, I'll be honest, is you can say, well, we'll try and maintain as much length as we can and just fill the gap with something else. So you could, in theory, go to bone graft, possibly with a masculate type technique. So put in antibiotic spacer and then go in a second stage and bone graft. When it's a large defect, doesn't tend to work brilliantly. The graft tends to slump and clump at the bottom and isn't actually contacting the bone all the way down. Professor Sharma showed in his talk a picture of the 3D printed cages, which we've used in 2 cases for this so far. First time ever in Hull. We'll tell you if it actually works, because we don't know yet. But generally, getting that to heal is again an ambitious thing. There are descriptions of other techniques, such as using a vascularized fibrillar graft. Difficult technique, hard to get to heal. Requires a lot of plastic surgery and not something they like doing in elderly patients. You can, in theory, replace this with a big lump of metal. But if you didn't want to go and put a joint back in that scares me an awful lot, I've got to be honest. And if that gets infected, then you've got an infection all the way up to here, and then your subsequent amputation is really, really high up. So that gentleman in the case example we talked through earlier actually went to Stanmore to discuss this, and they put him on the list for this, and then he got there on the day of the surgery, and they went, actually, this is ridiculous, we're not going to do it, and bailed out. Because I think they were worried of exactly that it was going to get reinfected. So yeah, I mentioned this, you can put lots of metal back on the inside. We don't like to, particularly because of the risk of reinfection. But it is a lot more, if you can, it's a lot more comfortable for the patient. I'll give it that. This is horrible to live with. And we've already talked about involving the plastic surgeons, because you will end up with knees and hips with multiple scars. Around the hip, normally they can use local flaps. Around the knee, the medial gastroc is really the workhorse. Free tissue transfer, anything further distal, it tends to be the best solution in a lot of these cases. So yeah, circular frames. I'll sell our favorite operations. So they do unite. You can move the fusion site. You can lengthen. You can do it all in a single stage, and they are very stable. So in theory, the patient can weight bear on them, but it's miserable for the patient, it's painful, and it takes a very long time to heal. And they're very bulky. So this was one of our, Yusuf was one of our fellows a year or 2 ago. He published our series on this. The average frame time was 13 months. So you've got to live with a piece of metal going from your hip down to your ankle for 13 months. 93% united, 100% infection resolution. Brilliant, we should do this for everyone. They were all, as far as I'm concerned, they were all miserable. Most of them hated it. Close your ears, Professor. And actually, our reoperation rate and our complication rate was approaching everyone. The majority of patients needed at least one secondary procedure to get to that point. So it's never a smooth course. But it isn't, and anytime someone's referred to me for this, I will say that this is something technically I can do. I am not going to sell this operation. I'll say that to every patient, yes, I will do it if you really, really want it, but you really have to know you want it. Ankles, a bit better, bit of a shorter frame time, so 237 days, so what's that, 8 or 9 months for these complex, still quite a long time, but at least it's below your knee. And 96% of those united, but again, 60% of those had some form of reoperation, even if that was just replacing a wire that had come loose or a pin that had come loose over that time period. So again, there will be bumps along the way. You have to talk to them about amputation. Don't be scared to talk to them about amputation. This is my last point, really. It's always an option. It's not a great option. No one likes admitting it's an option, but for some patients, that is the best thing. If they are not going to cope with all these fancy reconstructions and living with a frame and the clever things that we can do, this may be a less bad option for them in some cases. You have to realize that their function is going to decline with age. They're not all Johnny Peacock. They're not going to be running around. Elderly patients will struggle to mobilize, particularly with above-knee amputations. But it is a single procedure which does fairly reliably resolve your infection. There's a few interesting papers that I just wanted to end on, comparing AKA to knee arthrodesis. These weren't necessarily frame ones. These were sort of all forms of arthrodesis. And so this group found that there was actually no difference in infection between fusion and amputation, which surprised me slightly. I thought amputations would have less. Overall, they suggested that the above-knee amputations had less pain and were more autonomous, and had slightly better quality of life scores on PROMs. This one said exactly the opposite. So they said that those patients who'd had fusions had better physical component and mental component of an SF12 PROM score. And 70% of their patients said they would have a fusion again rather than having an amputation. So use whichever piece of evidence you want. Both operations aren't great, and neither is going to give you brilliant function. But I think both have to be discussed with your patient. And I just wanted to end on this. So this is an increasing problem. This is an American study. So overall, the incidence of above-knee amputations fell 47% from 98 to 13. But over that same time period, above-knee amputations specifically for PJIs increased nearly sixfold. So while we're getting better at not amputating vascular patients, we're having more and more patients with infected joint replacements who are having amputations. So it's just to depressingly illustrate, this is going to become a bigger and bigger problem throughout your careers, I'm afraid. So it is something that needs lots of thought and engagement. So in summary, yeah, there are various options. None of them are great. Limb salvage is technically feasible, and we think we're really clever. That doesn't necessarily mean it's the right option for everyone. And you've really got to spend a lot of time and involve the patient in the decision-making process, because it's going to be significantly life-changing whatever you do. And that's it.